Maybe I'll start with the answering the question of the collaboration. I just today checked the proofs for a paper that we've done together with the IBM research with the US colleagues, where we've formed a consortium with 5 big cohort studies, 2 of which are from the US and 3 from Europe, and collected or put the data anonymously together. And then most of the analytical work or the number crunching was done by IBM. So one part of that I was in charge of was the impact of growth on beta cell autoimmunity, and that is now published. And there are many other papers that came out from that, really putting internationally similar studies together. Another a little bit similar exercise has been Critical Path Institute, which is another American organization that has collected data sets from like the DIPP data set, DIPP is from Sweden, many data sets from the USA, TrialNet, the TEDdy study, and everything that they could get for European Medicine Agency and for FDA in the US to recognize that the appearance of certain biomarkers that I'm going to soon talk about can be used as staging tool for type 1 diabetes, so that in intervention studies, the outcome that you are studying would not be type 1 diabetes, because it's often way too far to reach in the clinical trial, but it would be the appearance or progression of these biomarkers, which would fasten the drug development a lot. And now, actually, next week, EMA will give its statement where they have accepted this new principle that then the medical industry developing drugs to prevent or delay type 1 diabetes can use that endpoint as the primary outcome. And then the next phase is to use it in FDA, and actually the DIPP data has been the crucial data set for the FDA to accept it. Because it was FDA wasn't happy with what all the other studies together presented, and then the DIPP data was needed to prove that it really is true what we were claiming. So there are some risk factors for type 1 diabetes, which if one has a family member with type 1 diabetes, or if one has a certain HLA genotype. And these can be used to screen population for follow-up studies. And that's what all cohort studies in the world have done thus far. And in Finland, we have used the HLA genotyping as the screening tool for the DIPP study. It started in 1994 in Turku. It was Olli Simel, Mikael Kniip, and Jorma Ilonen who started this study then. And soon after that, Mikael started in Oulu, and when he moved to Tampere, he started it there too. Now, Mikael and Kalle Kurppa are now still the PIs in Tampere. Mikael moved already in 1995 away from Oulu, and then Riitta Veijola has been the leader there and is the current chair of the DIPP study. And in Turku, Jorma Ilonen has retired, so Johanna Lempainen is now leading the screening lab or the immunogenetics lab that is doing the HLA screening for all these 3 centers. And Kalle Kurppa is the clinical PI in Tampere, and Heikki Hyöty is doing the virus research for all of these. So what we do is that we screen all the newborns that give the consent for that screening, and around 8 to 10% of them have HLA genotype that gives them an increased risk to develop type 1 diabetes. And those are invited then to the follow-up that is very frequent in the first 2 years and then less frequent thereafter. And what we do during those follow-up visits is we, of course, examine the baby and interview and get a lot of background data. But what is important is that we measure beta cell autoantibodies that are the biomarkers that give the risk of the disease. If we find them, then we follow them up to 15 years, every 3 months. So that means that some children who never developed type 1 diabetes during their childhood had 69 visits to the clinic and just donated blood and a lot of data, which has been very important. So altogether, during this 28 years, there's been more than 250,000 children that have been screened and almost 25,000 who have been followed. Only less than a third of these are in Turku, and Tampere has been the biggest center. There is more births than in Turku and Oulu there. Currently, there are about 8,000 children in the follow-up, and there are about 800 who have had at least one autoantibody, which come 4 biochemical autoantibodies that we are measuring, and at least 2 autoantibodies in 868. When this slide was made, was last year. And more than 500, actually about 600, have developed type 1 diabetes during these years. Early on in the DIPP study, it was found that the autoantibodies appear very early. And depending the type of autoantibody, the peak age of the appearance is different. So autoantibodies to insulin appear already during the first 2 years of life, most often. And then autoantibodies against glutamate acid decarboxylase, GAD, appear somewhat later, but then their appearance remains rather stable after 7 years of age, even up to adulthood. Whereas the insulin autoantibodies rarely appear later in life. Then sometimes there are also these insulinoma like antigen 2, but note that the scale is very different here. What does this matter? Here we see from the DIPP study that after appearance of the autoantibodies, the autoimmunity spreads fast, so that their other autoantibodies start to appear, and especially if the first autoantibody is insulin, so for the youngest. And if there are at least 2 autoantibodies in 5 years, close to 50% already develop the disease. In 10 years, 70%, and in 15 years, 84%. So most probably also the remaining 15%, or at least big part of them, will develop the disease at some point in their life. This is also from that tie-dye study that I referred in the beginning, which was done with 4 other cohorts. If there is only 1 autoantibody, 2 autoantibodies, 3 autoantibodies, you see that the number matters, and if you have 3 autoantibodies, then the risk is really high. In 10 years, it's approaching 100%. But it, depending whether those who have 1 autoantibody, whether they later on develop more autoantibodies, makes a difference. If there is only 1, then the risk remains rather low, only 15%. This just shows that we have to do something to prevent this development, which is called the secondary prevention. Or if we want to prevent the appearance of the autoantibodies, we should have that prevention already before there are any autoantibodies. It also matters at which age the autoantibodies appear, especially for the insulin autoantibodies, because if they appear very early in life, as they often do, then the progression to disease and to spreading of the autoimmunity is very fast. Whereas if the insulin autoantibodies appear late in life or late, this is sort of the oldest group, which is children more than 10 years old, then the risk is much smaller. So, but for the CADA, there is no difference between the age groups. So all the antibodies are not the same, and one needs to know what is the predictive value for each and for each combination and for each age. And those are some of the studies that we've done during the late years. These also seem to be different in immunology. And this is the study that was done in the TEDI, that is a similar multicenter study, but an international study where the Finns are part of. And Owen McKinney combined the TEDI data and the DIPP data from Riitta's Lahesma's group Henna Kallionpää's study that was deposited to the public data repository, and showed that if the child had developed autoimmunity so that there was the insulin autoantibodies appearing first, their whole blood transcriptomic signal was different from those children who had the CADA autoantibodies first. And those who developed the insulin autoantibodies first, that was characterized by the interferon signaling type. And there is also G protein-like receptor 171 as a target that was recognized, that if we could affect this signaling route, we might be able to prevent this cascade. Heikki Hyötys group has done a lot of virus studies, and especially enteroviruses, and found early on that the Coxsackie virus B1, which is an enterovirus, that is associated with the initiation of this IAA first type of type 1 diabetes. And in the DIPP study, we found that if the child had a prolonged shedding of this type of enteroviruses to their stools, that was associated with an increased risk of developing autoimmunity. So now much of the attention is now that whether prevention of this could prevent type 1 diabetes, and Heikki's and Mikael Nieb's collaboration with Provention Bio and with Factech companies have developed an enterovirus vaccine that has been tested in the phase 1 in Turku successfully, and will next go to phase 2, hopefully, to see whether we could prevent at least part of the diabetes with this vaccine. A combined risk score can help to predict type 1 diabetes, and this is also something that we are in making for the DIPP study. This is from the DIPP study. The autoantibodies and their number is really much better predictors than the genetic risk score, but the genetic risk score can give a good starting point to start to follow these autoantibodies, and hopefully we could move to earlier age to find the risk group where one could direct the primary prevention of this. This is a picture of the last in-person meeting of the DIPP, which has been sort of on remote meetings for the last 2 years, and it was in 2019 that we were in Oulu, and so we have a lot of collaboration here in the Turku Bioscience group, and there is Mikael Nieb and Riitta Veijola, the chair, and Jorma Ilonen, one of the founding fathers of the DIPP study, Suvi Virtanen, who has been doing the nutrition study in the DIPP, and Heikki Hyöty there doing the virus studies. So we have had a lot of collaboration in Finland and internationally. We have the highest incidence of type 1 diabetes in the world, and we have the largest type 1 diabetes study by far in the world. So this study is really giving a lot of possibilities, and it's not used to all its possibilities. So thanks.